I'm just going to bring in Gagan Mohindra, followed by Nick Smith and then Richard Holden. So Gagan Mohindra, if you can unmute. Thank you. Mr Mohindra MP.
Thank you, Chairman. Can I firstly declare that I am a councillor, just for the record? Just going back to the stress test for care homes, there is a perception that the social care side of the department is not treated as well as the NHS. Could I get your views on that statement for Catherine Francis? Oh, sorry, not Catherine Francis, for Roughton.
Roughton.
Thank you. Well, I believe that I've had all the support that we require from across the department and partners across government, and indeed the support we need working with local government and the care sector to deal with this. But as I think Sir Christopher said at the start, this is a different context from the NHS. You know, unlike the NHS, we're talking about thousands of small independent providers with a mixed funding model, and that's made it a very challenging and tough context for responding to COVID, which is different from the way in which the NHS operates.
And for Sir Chris, we've heard a lot about the evidence base determining decision making. Do you think there was sufficient data to drive some of the political decisions put forward by PHE and your own officers?
Would we have wanted, well, there are several ways of answering that question. Would we have wanted more data and more information about the disease when we took decisions? Undoubtedly, yes. One of our huge challenges, of course, this is a very new disease, and at the beginning of the outbreak, we were in a position where we had to take decisions for many of the reasons that Sir Geoffrey was setting out on the basis of imperfect knowledge. And we are still acting on the basis of imperfect knowledge. Some absolutely key things, particularly around things like the role of asymptomatic patients and the level of immunity that you get from having had COVID, are still medical and scientific unknowns. So we were undoubtedly in the position, and I think I said this in one of the answers to Sir Geoffrey, we were in a position of needing to take decisions on the best evidence that was available on that day. That was the right thing to do, but I wouldn't at any point claim that was perfect information. The other thing I would add, and it emphasises something that Ros has just said, is it's simply a statement of fact that we have much better information and much more timely information in the NHS than we do in the care sector. That's due to the structure of how those two things
but also
are done.
So Chris, wouldn't it also be the case that the fact that more testing was done in NHS and within hospitals rather than within care homes has inadvertently meant the data was better on the NHS side rather than the care homes?
Well, as I say, the decisions about how to use the limited testing capacity that we had were based on clinical advice. And just as a statement of fact, of course, the people who need testing most were people being admitted or in hospital who were showing symptoms that might or might not be COVID. And that was at the top of our priority list. That was a clinical priority, and in my view, the correct one. As we set out in previous answers, we were testing in care homes. That was one of our priorities, and as Ros described, as our testing capacity increased, we have massively increased the level of testing, both of staff and residents in care homes.
Mr Mohindra.
So, yeah, can I direct my question to Professor Paul Johnstone, because Sir Chris and others have said that it was based on PHE guidance. Obviously, there was a limited supply of testing. Did you feel you had sufficient information to ensure, to make the judgment call, and it would have been a judgment call, between frontline NHS staff and patients versus those in the care sector?
So I would like to answer the question about whether we have sufficient information about tests for outbreaks in care homes. When it comes to the difference between waiting between NHS and social care, perhaps I'd like to pass that back to Chris. But in we have been operating for years supporting outbreaks of all infectious diseases in care homes. Our local health protection teams know the care home sector, and in COVID, as in previous examples like norovirus outbreaks or seasonal flu, the care manager on suspicion of an outbreak would phone the health protection team, and the health protection team would arrange those 5 tests that we've heard about. That 5 is about being clear about the diagnosis, and from that, PHE local teams would provide advice on infection control, on isolation of patients if needed, on the correct PPE, and general cleanliness and disposal of waste. So I think we have sufficient data and information to manage those outbreaks in that real time.
Thank you. Can I just ask Mr. Mohindra if you could just lift his head a little, move his screen, because we can only see the top of your head, Mr. Mohindra, some of the time. Thank you.
So, thank you. So just going back to Sir Chris, hospitals got a stress test before the peak in infections. Why did this not happen in adult social care sector?
I'm not quite sure I understand the question.
It's about stress testing. This was done in hospitals before the peak in infections, but it didn't seem to happen in the care sector. Just want to know your views on that.
Well, I'll ask Ross to comment, but we've set out already at this hearing the measures that we took in care homes and why, which, given the differences between the sectors and our leverage in them, we felt at the time was commensurate with the needs in the 2 sectors. But Ross, would you like to add?
I think the only thing I would add is this is also, I think, a reflection about the different context in which we've got a local government role and a national government role in the care sector. So many local authorities will have stress tested their business continuity plans, and indeed over the past year there's been quite a lot of work done on that anyway for the care sector, because in respect of leaving the European Union. So I think what we were getting ready for is if there was going to be a surge of demand, so that we had the data around capacity, if we needed to get more capacity in the care sector, and that had been the planning that we'd done in from pandemic flu planning. That had been one of the things that had been highlighted that we might need to be thinking about. So I think that what I'd say is what we don't have is oversight of what every local authority and the NHS may have done at a local level in terms of testing those plans.
Okay, I think the frustration that we've had as a committee is that there's a perception that we don't have all the data to ensure that we can actually measure the impact of your decision making. I know there'll be subsequent NEA reports to do with PPE and the like, and hopefully that will flesh out some of those concerns that I personally have at the moment. The system at the moment seems to be a twin track between the NHS and social care. In hindsight, do you think it should have been a system-wide approach incorporating both care homes, adult social care, and the NHS?
So, Chris.
Yes, I'll start on that. I mean, just as a statement of fact, as this committee well knows, there are significant differences between how the NHS is run and how social care.
So, Chris, we do. I think we need to cut to the chase, as we do know that as a committee, as you say. So, can we cut? Perhaps you could answer Mr. Mohindra's question.
Yeah. Now, in this crisis, we have taken a more national and more interventionalist role in social care than we ever have before. And there has been actually a considerable amount of excellent working between local government and the NHS to deal with the issues that are arising. So we cannot get round the fact that these are very different sectors with different statutory bases, and one's a public service and the other is a number of independent providers. So the approach we took was certainly to look across the piece at what did we need to do to fight the infection as a whole, and then to be considerably more interventionist, both in terms of funding and guidance and intervention than we ever have before on social care, while promoting joint working between social care and the NHS, which, as I say, we've probably seen more excellent joint working between local government and NHS.
It's not quite that. We're talking about the specifics. Mr. Mohindra was particularly asking about a system-wide approach more generally, and we've talked to you twice before, at least to my memory as chair of this committee, about your role in shaping the market for social care, and your role in supplying medicines if there was a Brexit no deal, and we've been looking at this issue. So there are three areas where, as a department, you would acknowledge there's been a divide between what's happening in social care and what's happening centrally and nationally through our NHS. I mean, we could list some others as well.
I've never denied this, and they are services which, as you know, operate on a different funding basis and a different statutory basis. What I'm saying is that actually those divisions over the last 5 months, while we've been dealing with this set of questions, have been considerably less than previously. I'm not going to claim that we run them as a single national system, because clearly we can't. But we have pushed the limits of what we are able to do in terms of bringing the two together.
Mr. Hindra.
Thank you, Chairman. So just going back to my earlier question about the stress testing to do with care homes, you correctly pointed out, Sir Chris, that this is a very fragmented market. Wouldn't a stress test allow you and other policy makers to realise where the weaknesses were in the system and what intervention was required? Because you've intervened in certain points within the system, but not others. Yes. And we're just trying to get a clear rationale what the decision maker was behind that.
Right, well, and as you correctly pointed out earlier, we were and still are, in terms of social care, working with imperfect data, so we wouldn't disagree with that at all. And that's a ongoing debate actually with local government and with the sector. Now, as Ross pointed out, the way stress testing works in basically a local government managed service as opposed to the NHS is fundamentally different. So what stress testing was done in terms of social care goes mainly to local authorities themselves, who have primary statutory duty, and then local resilience fora. And that's the system on that side of the house. Obviously, the NHS is very different, and as part of the arrangements that Simon and Amanda put in, a lot was done at the national level. So there are systems on both sides of the house, but they are very different systems. Ros, do you want to add?
Yeah, if I can add, I think that at a local level, emergency planning is done as a system. And I've just, looking back, we reminded local authorities in March that they should be, by drawing on their pre-existing plans for pandemic influenza, should take a number of measures, which includes testing their business continuity plans, taking stock of how to maintain viable care home provision, look at how they work with the NHS to support care providers, and have a plan for how and when that would be triggered. I think the thing that we didn't have at the 13th of March, when we issued that particular advice, was getting all of that back in. I think now we have got from every local authority across England have sent us their care support plans, and we can see, looking through that, how far back some of that goes, which is what we would expect. So we have stepped in much further than we would normally in relation to local government as this has gone on.
Mohindra. Mr. Mohindra, I just need to unmute Mr. Mohindra. If you stay unmuted while you're asking questions, please, that'd be easier. Thank you.
Apologies. Thank you, Chairman. My next question is to Catherine Francis. Obviously, we've just heard from colleagues at Department of Health and Social Care that the onus was on local government to check whether care homes had sufficient capacity and stress testing. Can I get your views on that?
Yes, of course. In terms of, and if I may come back on your question earlier about joined-up planning as well, alluding to the point that Chris Wormald made about LRFs. I mean, on local government's role, I think the key point is that local councils do have statutory responsibilities to manage their market, to ensure that they have a continuity of provision, and they play a really lead role in terms of the local infection teams working with Public Health England and others in getting out there amongst care homes normally. So I think what we've asked them to do in central government is essentially a sort of extenuation and a lean into that role, and we have worked with them and supported them quite heavily in doing that. So when they're looking at the moment about their local plans for social care, they're really bringing together all of the local parts of the jigsaw. So they're confirming, do the NHS play their role in care homes as expected? Is the funding flowing through? Are the infection plans in place? They're bringing it together, and I think that's what we've tried to resource them to do. Just looping back, if I may, on your point about joined-up planning, Chris Wormald alluded to local resilience fora, and I think it's just important to note that all parts of England do have these resilience fora in place. And as you probably know, they bring together NHS as well as local government and all the Category 1 responders. And we work for government with those LRFs in each place. They have all had plans in place, and we have had very close contact with them throughout this crisis to hear the key messages that they're feeding back to the centre and where they are requesting help. And it's helped form government's response and government's policy in areas like PPE.
Right. Can I, Mr. Mohindra, have you got anything else? Or